Hello, my name's Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology at Duke Cancer Institute in Durham, North Carolina. Our choices for second-line small cell lung cancer are influenced by a number of factors. I think if we kind of look at the field, we've adopted platinum etoposide plus immune checkpoint inhibitors as our first-line therapy. And previously, we had single agent pembrolizumab or nivolumab or potentially nivolumab and ipilimumab as second-line therapies. But now that we're using immunotherapy in the first-line setting, that those are not as available to us as second-line options. And I think it's a quite difficult disease space to treat and also to really determine what's the best therapy. When I see a second-line patient, I look at a number of different factors, such as the treatment-free interval. And classically, we've defined chemotherapy refractory as patients who've had disease progression within 90 days of the last chemotherapy, or if they've had disease progression after 90 days. And this is a rough estimate of the potential efficacy of second-line chemotherapy. Other factors are the performance status, how well do they tolerate the first-line therapy, and what are the patient's wishes at this point. When I look at the options, I think topotecan remains an option. I think the FDA-approved schedule of daily for 5 days in a row every 3 weeks is very onerous, and it's not particularly well tolerated. Other options are lubernectinib, showed some promise in a phase 2 trial with a reasonable response rate and was approved. We know that the Atlantis trial, which compared lubernectinib with doxorubicin to either topotecan or CAV at the investigation discretion, had similar overall survival. I think I'm eagerly awaiting the presentation of the Atlantis trial and then the full peer review to really see how the efficacy was in the phase 3 trial, the toxicity as well. I think that other factors, I think if some patients have had a prolonged treatment-free interval, like 6 months, I'm more inclined to go back to a platinum combination, either platinum etoposide or platinum irinotecan. I think single-agent chemotherapy is still frequently used in this situation. I generally use one of the ones that's included in the NCCN guidelines at this point.